kinds of winners here. We have dogwood winner, blackberry winner, redbud winner. Yeah,
wow.
We name our cold snaps.
I am from Newfoundland and Labrador, and Sheila's brush is something you'll hear a lot of at this time of year. Oh, we had a visit from Sheila's brush last night, which means a dusting of snow and wind. So it's very colorful, all of these expressions.
Well, that's my co-host there, Juanita St. Croix. Thank you so much, Juanita, and also Babs Tierno, our producer, is here today. And we have a great guest, someone I've really been waiting to hear from. We've actually had Dr. Tim Barksdale as a guest before on CCN. And so we're so glad to be able to have him back today to talk about mental health disparities for adults with IDD. Such an important topic for us to be discussing, because we still have work to do to try to get people the type of mental health care that they need. And so Dr. Barksdale is going to talk to us about that in just a moment. This, of course, is our fourth Tuesday feature. We do this every Tuesday at 12:30, but on the fourth Tuesday of the month, we have a NADD collaboration, and Dr. Tim Barksdale is one of the members of our board, so we're so happy to have him here today. Next slide. So just a few things about what we have upcoming on CCN. Next week, we have Kim King, who is with the National Association for Mental Illness. She is the CIT trainer. If you don't know what CIT is, that's Crisis Intervention Teams. So the police officers across the state who get specialized training in working with people who have mental illness are trained by Kim. And so we're so happy to have her here next week to talk to us about the work that she's been doing. On May 9th, we have a case presentation. We don't have a lot of details yet on exactly what that's going to be, but I'm sure it's going to be an exciting presentation that we can all learn a lot from. On May 16th, we've got mental health, starring Michelle Bagby. She is the director of the START program. She's going to talk some about START within the context of that presentation on May 16th. May 23rd, we have our next NADD collaboration starring Dr. Brandy Kelly, who Juanita recently got involved in this. So we're very happy to have her next month on our fourth Tuesday feature. And then on May 30th, we have Tennessee Association of Mental Health Organizations talking about 988, the suicide hotline, essentially, with volunteer behavioral health is going to be here. So we're excited about these upcoming presentations that we have. So with that, I'm going to turn it over to my co-host, Juanita St. Croix, for an introduction.
Well, thank you very much. I am delighted that Dr. Tim Barksdale is here with us today. So Dr. Barksdale is the Senior Executive Director of Clinical Services for Marikey, where he supervises a clinical team of 50 clinicians with adults with IDD and mental health challenges. And that's across 5 states. And I had to look up these abbreviations. I am so sorry for that. But I learned Pennsylvania, Delaware, New Jersey, I knew. That one's pretty easy. The next one, Virginia and California. Yay me, I remembered. So Tim is a doctor of clinical psychology, a licensed master social worker, a mental health first aid instructor, and he has been the recipient of the Pennsylvania Psychological Association Early Career, PPA. Oh, it's a big break there for no good reason. Psychologist Award. I thought that sentence didn't make sense, but it is the Psychologist's Award. PCOM Distinguished Service Award, NADD Member of the Year, and many other awards as well. We have quite a distinguished guest today. Dr. Barksdale serves on the NADD Board of Directors. He is the co-chair of the NADD Clinical Certification Committee. He's on the Board of Governors for Friends Hospital and was elected president of the Pennsylvania Psychological Association, and his presidency starts this June. That can only be just a wonderful thing for the Psychological Association. Dr. Barksdale has worked with adults with intellectual disability since he was 16 years old, when most still lived in institutions. Tim is also the I said that NADD Member of the Year. He's a Christian, and his greatest achievement is being the proud parent, proud father of a 19-year-old artist and musician son. So we are going to get to meet Tim personally very shortly, and he's going to tell us a little known fact about himself, which brings us to our wonderful Smarticle. Again, my very favorite part of this. So I took one of the sources that Dr. Barksdale has cited in his research and looked at eligibility criteria in any NIH-funded clinical trials. Can adults with intellectual disability get in? The authors, Dr. Catherine McDonald, Dr. Ariel Schwartz, and Dr. Maya Davitello. And there's a citation for anyone who would like to look that up further. So Catherine McDonald was the primary researcher for the study. She's a professor of public health and associate dean of research at the Falk College of Sport and Human Dynamics. She and her fellow researchers conducted the study to address the following. Scientific breakthroughs aren't possible without the painstaking process of clinical trials. So what happens when many of those trials leave out large portions of the population, such as people who have an IDD? I'm going to go ahead. Next slide. Thank you. Why is it important to include people who have an IDD? Research in clinical trials provide us with the development of ways to detect, diagnose, treat, and prevent diseases. Clinical trials improve the health and well-being of individuals and populations. So that includes people with an IDD. The study was conducted, the research looked for criteria for inclusion, direct exclusion, indirect exclusion of adults with an IDD in the National Institute of Health's funded 2, 3, 3, and 4 clinical trials in the United States based working-aged adults, so anyone 18 and over or under 55. I don't like that we're now discluding people over 55, having just recently passed that marker. So the main findings of the research: funded studies with direct inclusion criteria were very rare. And so it was very rare to find a study that intentionally included people with an intellectual disability. 74.6% of funded studies had eligibility criteria that directly and/or indirectly excluded adults with an IDD. Approximately a third of the NIH-funded studies have direct exclusion criteria based on the cognitive impairment or diagnosis. Nearly 65% of studies indirectly excluded adults with an intellectual disability based on factors likely associated with functional capacity, inability to read or write, or research staff discretion. So what these findings mean: eligibility criteria for trials exclude any indicators that adults with IDD are included. For example, no plans for accommodations for adults who have low literacy and indications of inclusion of adults with legally appointed guardians. Almost 3/4 of all clinical trials have eligibility criteria that can easily result in the exclusion of adults with intellectual disability. And this is within the NIH-funded studies. These findings suggest substantial cause for concern that adults with IDD experience widespread exclusion from NIH-funded clinical trials, exclusion that may lack appropriate justification and assessment. Consequently, this group is denied equal access to the potential benefits of scientific discovery. I don't think that's news to any of us working in the services. So what solutions does the author propose? Enhancing consent and capacity via environmental modifications to increase the understandability of consent materials. Create meaningful assent procedures when someone does have a legally appointed guardian. And each of these studies requires rigorous scrutiny of eligibility criteria and assessments so that criteria are appropriately justified and assessed by standardization processes. So there's no longer room for the discretion of the researcher, that the criteria are very clear. I think There we go. That brings us to the delightful Dr. Tim Barksdale. Welcome, Tim. We are so happy to have you here and sharing a very little known fact about yourself.
Well, I'm delighted to be here. Should I just start sharing my screen right away?
Sure. Unless you're gonna, put on a costume like a rodeo clown or something.
Not this time.
I say that because that's Bruce. He didn't dress like the
I've
clown.
never been a rodeo clown. I did participate in rodeos earlier in life.
I know that. I just tell everyone it was a clown.
Although I was a clown sometimes and in a rodeo, so maybe that does fit.
Maybe.
Well, Juanita, I'm really glad that you shared that article, because what I did was my research actually took place 10 years ago. And as a kind of an anniversary gift to myself and the need to know what's been happening since then, I started up a new project. So what I sent you was updated stats and articles that you could look at. So yeah, that's a major problem, clinical trials. I mean, that talks about, people with intellectual disability not being included in psychological assessment trials, as well as psychoactive medication. And so with all the genetic differences that you have, that would be really crucial that they would be included in these, because these are the medications that we use to help support them. So my research.
Wait now, your little known fact, sir.
Oh, little known fact. Wow.
We're not going to let you forget that.
No.
Let me try to think about that. All right. When I was younger, I was the tallest gymnast in the city.
Wow.
And I specialized on the floor exercise.
Okay. So you could actually, I know that you were able to like do flips and other things like that.
Yeah, as a matter of fact, when I was in California 2 weeks ago, they called me on it, so I did a cartwheel in the classroom.
Oh my.
Wow.
And aren't these maneuvers more difficult for a taller person?
Yes.
Yeah, it takes a little bit longer for all our limbs to kind of get around. So yeah, I'm 6'4".
I'm so impressed.
There you go.
I'm picturing a NADD talent show.
Oh.
Yeah, you're undoubtedly very talented to be able to do gymnastics to begin with, and then to be able to do it with the additional impediment of the height is amazing.
Yeah, and then the additional impediment, the fact that I'll be 60 next year and I can still do a cartwheel.
Oh my, yeah,
Wow.
that's quite impressive. Quite impressive.
It sure is.
All right.
Thank you for that. Now you may proceed.
Now I can proceed. All right, thank you. All right, so I'll just get right to the topic. All right. So now when I did this research, there were about 3 million people diagnosed with intellectual disability. Now that number is 6.5 million. And I'm not sure, but back then it was 3% of the population. That might have moved up a little bit, but not much. What we do know is that people with intellectual and developmental disability are more likely to have mental health disorders, and that there are treatments that work for this population. Most of the research came out of England, but now it's being used more readily in the United States, especially members of NADD who are NADD certified. And that people with ID, they respond to treatment. So we identified the problem in terms of when we looked at mental health programs, community centers. And by the way, my research took place in the state of Pennsylvania, and that's going to be expanded as I work with NADD to make it a more national and maybe even some international features. I know that Juanita was saying that she didn't know how the numbers in Canada compared. So we're going to be answering that question. But anyway, one of the things that we noticed was that there just were not enough clinicians who were providing services. And when I say clinicians, I'm talking about psychiatrists, psychologists, social workers, all those who provide therapy. So in doing the research, I had come up with some hypotheses. And so I predicted that they were just not being educated. The doctors and psychologists, they just weren't receiving the education. And I based that on my own experience. I know that when I went through my doctorate program, I had one class, it was behavioral techniques, and it showed a black and white film of behavior modification, and that was it. That was my only education. So when I went on my internship, because I had been in the field since I was 16, whenever I was at a psychiatric hospital, it's like, hey, call that intern. He knows how to handle this population. And I'm like, hey, I'm here to get an education. I'm not here to teach you guys. But that was frequently my experience during my practicum time, and as well as my internship, is that whenever anyone was faced with anybody with intellectual disability, I would be called in. So that's how I came up with the education, and then exposure. It was not until, I guess, 1987 where we started seeing some real movement of institutions closing, at least in Pennsylvania. And I know in California, we work regularly in California. We're just now closing down the last of the institutions. So that means that a lot of people, when they went to school, when they were in their primary education, they just were not exposed to people with intellectual disability, even in their families, because people were sent away to institutions. A lot of times, at birth, they would just recommend, hey, this is best for the child, and the parent, not knowing better, would do that. And then the last one was attitudes. The prediction was that if they had less favorable attitudes towards people with intellectual disabilities, then they would be less likely to work with the population. And then hypothesis 2 really talked about diagnostic overshadowing, that people would just dismiss this population and say, well, no, they can't have depression, they have an intellectual disability, which was very prevalent. And that they would have, the higher level functioning of the person would kind of dictate how much treatment they had. And then the therapist's confidence in their own ability would play into that. So I'm not going to get into the weeds and really geek out. So I took out all of the statistics and the research stuff so that we can really kind of get to the discussion. But I did use 3 tools, just finding out the basic demographics about the group. I developed a questionnaire called the CTQ, which was the Clinical Therapist Questionnaire. And then I used another document called Attitudes Questionnaire that was already established, and I got permission from the author to use that. So in order to be included in this, a survey went out, and I used Psychology Today. I was able to find a lot of people through that website. I worked with the Philadelphia College of PCHC, Philadelphia Coordinated Healthcare, which is a healthcare quality unit, and they helped me do a lot of this research, and I got a grant. But anyway, you had to have a master's degree. You had to provide therapy. You either had to be licensed in Pennsylvania and a psychiatrist licensed in Pennsylvania. And when we were looking at the issue of exposure, we kind of broke that down into having no contact, an acquaintance contact, which would be your neighbor or your church member, casual contact, which would be if it was your client, your coworker, an employee, and then close would be a relative or a roommate. So in terms of people who responded, our greatest number of responses were females under the age of 35. The majority were white because, that's the field of psychology and psychiatry. There's very low representation of minorities. And in terms of who responded, most of our responses were actually from unlicensed therapists, because you have therapists who are associated with hospitals and community centers who, as long as the hospital and the community center signs off, they can provide their therapy. Next was the licensed social workers, licensed psychiatrists, psychology students, and licensed psychologists. So even though I was initially targeting psychologists, it seemed like we got responses from a larger group. So it's going to be interesting because right now I'm doing this with the Pennsylvania Psychological Association, and the responses have been fair, but we're going to continue it.
Kim, this may have been our previous slide. What were the total number of respondents?
So it's interesting when people do surveys, depending on the questions, you had different numbers. So overall, we had about 294
Okay,
professionals.
that's a pretty good number.
Yeah, we were very happy with that. So the first thing we looked at was the orientation, the therapeutic orientation of those who responded. So we got the most responses from therapists who did interpersonal therapy. And then second was the humanistic or person-centered approach. Dialectical behavioral therapy was probably the lowest. Next is psychodynamic. So very few therapists who practice psychodynamic therapy work with this population, which is understandable because it's largely a talk therapy. So the top grid just talks about the response level. But when we talked about what services did you use, if you did use therapy with this population, people with intellectual disability, and the most used therapy was interpersonal. Second, person-centered therapy, dialectical behavior. I'll be interested in that because we started at my institution at Marikey. We've started, thanks to Robin van Erten, actually piloted a program where this was used for somebody who had frequent psych hospitalization. And as a result of her intervention, the hospitalizations dropped. So she's going to be doing her world tour and talking about that. But here's the interesting piece now. So of the respondents, we were happy to see that 58% did treat people with ID, and only 42% did not. Again, we're only talking about people in Pennsylvania, and we're talking about people who responded to the survey. So a lot of times you have to kind of recognize that if you're not interested in the population, you might not even respond to the survey. But when we asked how many people received education on this population, many of them were like myself, and got very little to no education. So 67% said that they hadn't received any, and only 33% had received some type of study. And it could have been as minimal as mine, that one class, that one film. So then we asked them, that 19% should be, oh no, let me do another one. There we go. We asked them if they received training, if they received an education, would they be more interested? And the great thing was that same number of people who responded, they said if they had received the training, they would be more likely to work with this population. And only 32% were not interested. And then we asked, would they add this to the practice? So 63% said they would, 18% said they wouldn't, and 19% were undecided. So we asked them, well, what are the factors for not treating this population? So in ranking them, the number one reason was that they had not received any training or education. They thought they'd be too busy. Number three, they didn't have any experience being around the population, which speaks to the question of exposure. They thought that they would get less money because of the medical assistance issues. So they were concerned about the compensation. They were concerned that their staff, whether it was the wait staff, the other therapists, they just thought that, no one would be equipped to work with the population. There were safety concerns. And then back to the diagnostic overshadowing, they just thought that people with IDD would not benefit.
Tim,
Mm-hmm.
did you encounter the challenge? I know I was asked to speak to a group of graduating psychiatrists about coming into the field, about specializing in mental health for people with an IDD. And largely they said they were concerned about the lack of resources. So the lack of expertise in people to go to if they met a challenge, the scarcity. Was that something that you encountered or
Yeah,
on any of it?
I think that's part of it. I mean, if you don't have schools that are providing this training, and you do go in there, you'd have to be largely like myself and train yourself on it. And mine was from being experienced as a direct care professional and program specialist, kind of working my way up through the chain. That's how I was exposed to the population. But yeah, I mean, when I would talk to colleagues and talk about the benefits, I would try to really sell it and say, hey, you have people who are in a residential program who have staff. So, your no-show rates are going to go way down because you have staff who their job is to bring them to their sessions and things like that.
Right.
Yeah, that was the concern.
Well, if you couldn't convince people, I had no hope.
Yeah.
Yes.
Tim, some people indicated that they were too busy to do this. Was there some indication? I don't know if your responses were able to get to this point or not, but were people too busy because they thought it would take more time to work with people with intellectual and developmental disabilities? Or was this more or less just kind of, I mean, you could almost say, well, you're too busy. Are you too busy to do your regular work? So I don't know. I don't know if you're able to characterize that any further, but just was curious.
Yeah, I mean, you have to think that it was just largely an excuse. But now more interesting, because we're replicating the study and we're doing it now, too busy may be number one. Because after COVID, there's just a drastic shortage. Well, you had COVID, you had the racial issues that happened in the country, the gun violence, all of that has just really kind of sucked up all the resources.
Yeah.
So it may be more legitimate now.
Tim, we did get a question that I thought we could go ahead and tackle since we're on the slide.
Sounds good.
Did you ask those who provide services for folks with IDD how many provided for folks who do not use their voice to communicate?
That's a good question. And I can't remember now if that was but I would guess that they did not. That most of the people who were receiving therapy were people who were moderate to mild range. As a matter of fact, that's why for the NADD clinical certification, we changed the criteria. We had 5 competencies, and one of them was therapy. And so we expanded that to be any type of therapy. So rather than just psychotherapy, we started to say that, you had to have an awareness of any type of therapy that would support that individual. So that could be play therapy, that could be occupational therapy, physical therapy, something that would expand that person's life beyond medication and traditional treatment. Good question. And we may want to kind of really look at that. I'm going to actually write that down for the next one.
I also want to remind everybody out there, if you have questions, please put them in the chat, or, wait until a little bit later time where we're able to call people off of mute so that you can come on and ask your questions directly to Dr. Barksdale. But if you have questions, want to put them in the chat, please do so as we're going along, and we'll get to those as we progress.
Okay, yeah, because we're almost, let's see here. So in terms of the, I must have had two sets. Okay. So CBT, when we looked at and kind of broke down all of the things in terms of being most successful with this population, cognitive behavioral therapy kind of won out. And then interpersonal therapy still was the most frequently used by the population of clinicians that were providing the therapy. And of course, there's just low levels of education being provided. And the hopeful part of that was therapists expressing the fact that if they received the education, they would provide the treatment, and that universities are just really lacking when it comes to providing this type of education. Now, the interesting thing about this is that, and this, I just found this out maybe 3 weeks ago. I was talking to my clinical team doing group supervision, and I was telling them about this presentation. And one of our interns said, well, she's doing her research and she's actually going to the universities. She's just starting her dissertation, and she's going to the universities and asking them specifically about their curriculum and how they are providing training. And that is Samantha Warner, who also has her NADD clinical certification. So it's a good thing. So the quote is, these continue to be significant gaps in services available for individuals in this community, one of the most prominent being in outpatient and mental health care. So the factors that she found out were that, so now that individuals with IDD are, their life expectancy has more than doubled. People with Down syndrome are no longer dying from, dementia. Let me just get a little information on that. So yeah, in 1983, the average life expectancy for somebody with Down syndrome was 25 years old in the 50s. Oh, I'm sorry. 60 years old in 1983, but going way back. In the 50s, the average was 13 years. So things have increased quite a bit. So over the past 73 years, the average life expectancy of individuals with Down syndrome has quadrupled. So that means there's more people who need services. And so the gap has just really kind of exploded. Another thing she found out is that and this is just from the research, she hasn't started her own study yet, but that just in terms of initial questioning, 74% of the respondents indicated they believed that individuals with IDD needed a specialist. So really just anybody but me. And the majority of the people who had any exposure to the population was really people who kind of knew them personally, but not really in their settings. And then only 17% were kind of dedicated to saying, okay, yeah, we're willing to see this population. So we're just really looking forward to the research that she's going to be doing. She has had some initial findings, and that would be that of 4,000 colleges across the United States, only 21 programs provided any type of training for people with intellectual disability. And then she kind of lists those here. 15 were specifically for working with children with autism under a school counseling concentration. So that wasn't even IDD. Only one was a general disability studies program, and that was in the City University of New York. Two of the universities had a 12 credit course that was postmasters. And then one was a 12 credit course, which was master's, which was in Temple University. So she's just doing this research. When I did mine 10 years ago, Temple was the main one that provided it, and that's in Pennsylvania. And then there are 2 master degree courses, and those are found in Ohio State and in Florida. So I am actually going to be talking about working with her, because if we combine our research now, we'll have a lot of information. And I know that a lot of members of NADD are always talking about going into the universities, going into the psychiatric hospitals, going to the community centers and educating people. But it looks like what we need to be doing is going to universities and developing courses and curriculums and actually providing this training. So that is it. I don't know if I can stop sharing.
Okay, well, Babs, do we have questions in chat?
We do. So Margaret responded to your response to her question and said, "Thank you. That's my experience that therapists will work with folks who can engage in talk therapy, but not if they don't use their voice. I see folks who don't use their voice, and we still do what I would define as talk therapy, but adapted for communication needs." So that was just a response to your response. And then we have a question. Any theory as to why, with a substantial population of IDD people with a substantial number of clinicians willing to treat them, why there are so few course concentration options for working with this population?
Well, and that's the question we really want to answer. And I think Samantha is doing a really good start in doing that. I just think it's off people's radars. Like I said, we're talking about people who established these programs who didn't have any exposure to this population. It just never maybe even occurred to them that they would have that. I mean, we still have clinicians, we have psychiatrists who, when it comes to mental health needs of people with IDD, they go, oh, well, they just need a behavior plan. And we have some of the psychiatric hospitals who will admit someone who is clearly psychotic. And then once they find out that the person has IDD, they go, oh, no, we just need to send them back. Regarding the person who talked about providing treatment to non-speaking individuals, I'd really like to hear more about that. Maybe you can send us a link, or maybe use my contact, but please reach out to me, because we support a lot of people and we'd like to hear more about that.
So, Dr. Barksdale, it seems like in that listing of different programs that are out there, we've got the one from Ohio State, and I think we know some people who came through that program, right? That was Stephen Reese was sort of the purveyor of that program. And like, as an example, Jim Wiltz, I think, came out of that program, but very few people are, that have come out of that one program. I'm not familiar with the one in Florida. Is that an extension of the Ohio State program, or is it a totally different program? I'm not, and you may not know the answer to that. I'm just wondering.
I'm not sure. I was surprised to even find it. So,
but it seems like one of the things you're saying is that we need more of those types of programs throughout the country.
Yeah, I know that some people have started programs in community colleges. So I don't know if they're off the radar, but I know that's a place where people can get some of that.
I know that always bringing in the Canadian perspective, they're not always, just when I know it, or I'm okay making it up. But there are 13 postgraduate Canadian or universities with disability studies programs postgraduate. So I think we have fewer numbers of universities and colleges. So colleges are certificate and diploma in Canada. So that's the difference between colleges and universities here.
Okay.
And it's the universities that are offering the postgraduate work. Colleges do have certificate programs and diploma programs for developmental studies. Not all of them, but a large number of them would. And that's largely for direct support professionals.
Okay.
So.
And that'll be interesting to see how that's broken up. Right now, we're kind of clustering colleges and universities.
Yeah.
But it may be the same kind of breakdown.
Yeah. The great Dorothy Griffiths is Canadian, of course, we know, and with Brock University in St. Catharines, Ontario. So that's one of the big places for studying in Canada. Everyone wants to go to Brock.
Yeah, that's a pretty impressive alumni there.
Yes, very much so. Very much so.
We have a lot to learn from Canada, as we know.
And no, in all fairness, Canada has a lot to learn from the U.S. as well. I am a great fan, and I see Margaret has put in that most don't provide, but I would say most colleges in Ontario do. Maybe they don't in all other provinces, but there's a large number of programs at the college level.
Well, we need to learn more about these programs so that we can start replicating them in other places, I think, and see how people have done it.
Yeah.
Because that's a significant deficit, I think.
Yeah.
Yeah,
I
and
think
Bruce, that's a good point. I mean, you don't want to reinvent the wheel. If there's curriculum out there, we can just.
Yeah, and I think there are curriculum out there. I think the UK leads us greatly with research. UK, Australia, New Zealand, these are places that are really on the cutting edge of training professionals. So I'm always respectful of their work, but you have a very active disability network in the United States, and it is not replicated in Canada. So I think, when we talk about we have this, you have this, we balance out, I think, in the long run, because there's some phenomenal work going on here in the US.
Yeah, you're absolutely right about UK. I mean, I would say 50% of our research came from the UK.
Yeah.
They're just, they were leaders in the cognitive behavioral training, not just for, regular population, but definitely for people with IDD and for people with autism.
I chalk it up to them being a really old country. So, they had to go into new fields.
But they had a head start.
So Canada, the US, not so old.
We did get a comment that says, "Thank you, Dr. Barksdale. I referenced your study in my own dissertation and subsequent curriculum development for clinicians who wish to serve this population but had received no formal training. Unfortunately, in Alaska, we still see the same disparities almost 10 years later."
Well, I'm very honored. I know that when I started with NADD back in 2007, I was a doctoral student, and I was writing this dissertation, and then everybody who was on the committee to develop the different certifications were people that I was quoting. So I was kind of completely geeking out and in awe. So it's nice to kind of pass that along. I know somebody asked if they were able to contact me. I put that my email in the link in the chat.
So when is it you anticipate launching the next study, Tim?
Well, it's already been launched in Pennsylvania.
Mm-hmm.
And in terms of with NADD, I will, pull you and Jean together, and we'll try to figure out when that makes sense.
I think yesterday makes sense. So.
Yeah, as soon as possible would be a good marker for that. So, Tim, talk a little bit about your interface with the Pennsylvania Psychological Association. I mean, this is a tremendous thing that we've got an IDD person who is the president of a state organization. Tell us a little bit about how that interface has helped you, or if it has helped you, how has helped you shine a light on people with IDD.
Yeah, I mean, I'm really looking at this opportunity to do just that, shed a light on this population. So my first step was to transfer the survey and the Pennsylvania Psychological Association. They took it in. They so they're collecting data for me. And what I'll probably do is just go ahead and talk to NADD and use that NADD distribution so it'll go beyond Pennsylvania. And we may end up looking at two sets of numbers, what's going on in Pennsylvania, how things have changed since my original study, and then how does that translate to the greater United States. So they've been very cooperative, the association has. And now I know that in June of 2024 is my convention. It'll be in Lancaster, PA. And the focus is going to be, the theme is called accessibility, playing on the term accessibility. And we're really going to be educating. We're going to have workshops. We're going to be accepting workshops on various levels of treatment for this population. And just to expand it, we're calling it accessibility because we're going to look at the full spectrum. So not only we're looking at people with intellectual and developmental disabilities, but also the other end, the geniuses and the high performers.
My sense is from what you presented that the results would probably be the same in most other states, but I know you work across states. Do you find that this is pretty much a universal, or are there any differences that you've seen just anecdotally out there?
No, the only difference is, I would say, it's interesting. I think it kind of correlates with how quickly institutions close down. So in Pennsylvania, they were kind of ahead of the curve and they closed down a lot of institutions. So you have people who are more willing to work with the population, more aware of it because they've known people who've worked in the institutions. They got some of their early jobs, like myself. I mean, my first job, I worked at a camp where we took people out of the Pennhurst institution and provided them with 6 weeks of vacation, and we exposed them to different art and music. My job was, I was a program specialist, so I had to go and saddle the horse and ride it down the mountain and have people go around in circles and that. So the interesting thing about that is that I did that as a teenager. And then one of my first jobs after being a direct support professional was to monitor all the people who came out of Pennhurst. So it was kind of like a reunion every day. And my job was to talk about the quality of life that they were receiving. And this was part of a lawsuit where the city of Philadelphia was being sued to the tune of about $1 million a day because they in essence had created lots of mini institutions. They put people in the community, but it was staffed by the people who worked in the institutions, and they were still being treated the same way. So, my group kind of worked to reverse that.
I think no matter how well planned transitions from institution to community are, there are inherent difficulties, and not just with the lack of mental health professionals in the community. I think it's lack of resources in community. We work hard for transitions to be as smooth as possible for people and set up the services, but they never really, so much work still needs to be done when people move for them to really be able to access their citizenship. So
yeah, I'm experiencing deja vu in California because
yeah.
they're just now closing institutions.
Mm-hmm.
And what they typically do is the people who run the institutions are now responsible for monitoring the community homes. So they're using their old standards.
Yeah.
Yeah, so.
Yeah, and as I think about it, going back to your 58 to 42 number of people who actually had served somebody, that's probably a higher number, especially if you go back to 2010, a higher number than in most states
Mhm.
that are available, that will serve or have served a person with intellectual or developmental disabilities.
Mhm.
Another question I have, Tim, is about the NADD-CC program, which I know you oversee that for NADD. And what role can that play in this process of trying to identify more providers out there, if
Well,
any?
I'm not sure about more providers, but I know that in terms of quality providers,
Yeah, okay.
because, in terms of the gold stamp, when someone goes through our program, we're making sure that they have an understanding of the biopsychosocial approach, that they're looking at medication, that they're looking at diagnosis, that they're looking at therapy, that they're looking at cultural issues, as well as medication, and able to put that up all together in a case conceptualization when they are providing supports. So if someone has NADD-CC behind their name, you know that that's going to be a quality provider.
And Tim, that certification is available to any licensed clinician, correct? That has experience with people with IDD. Is that accurate, or did I
Well,
miss that?
it's getting there. I mean, because they have to have at least 5 to 7 years working with the population before they can apply. And they don't necessarily have to have a license. We
Okay.
are, because there are a lot of behavior specialists who've worked in the field for many years. So if you have at least 10 years of experience, and you may not even have a master's, but if you can put together a great, work sample and really kind of talk through the process, and you demonstrate a clear understanding, you can be certified.
Babs, do we have any more comments or questions from chat?
Margaret posted a documentary about an institution in Ontario, but other than that, no other comments.
All right. Well, Dr. Barksdale, thank you so much for being our guest today. We so appreciate you sharing your experience and your research here today. I think this is a great, very educational program for all of our audience. And so we thank you so much for being our guest.
Well, thank you. It's been an honor. It's a fun discussion.
Yes.
Of course,
Yes.
I want to acknowledge my co-host, Juanita St. Croix, our producer, Babs Tierno. By the way, Babs Tierno did a fantastic job putting together some law enforcement videos that are going to be available soon in our state. And these are what we call micro learning opportunities. Babs, why don't you just come on real quick and talk about those micro learning opportunities quickly?
Okay, we've put together these short learning videos where instead of having two trainings per year where you sit down and learn about IDD in a classroom setting for law enforcement and EMS, and then you don't talk about it for 6 months, and then you do another training, and then you don't talk about it for 6 months. We created these very short videos to keep that conversation going all year long. So the hope is that officers or captains and lieutenants would then play those short videos and have conversations about very specific topics within the IDD community, such as maximizing communication or understanding least restrictive environment, those types of things, so that we're having that conversation all year long.
That is fantastic.
Those will be available on our website.
Wow.
I put Babs on the spot. She wasn't expecting that, but I did want to make sure I gave her a shout out because this is a really great thing that she's put together. Again, thank you, Dr. Barksdale. And we thank all of our audience. We do this every Tuesday at 12:30. It's the Clinical Consultation Network. Join us again next week. We appreciate you.
Thank you, Bruce.
All right. Thank you.
Take care.